for the organization. And I lectured in many countries the last 25 years, 30 years, but rarely I experienced such a hospitality as we had here. And I think all my colleagues from abroad will confirm that, and that's all thanks to the organizing committee, and particularly thanks to Professor Adel. Thank you very much, Adel. Thank you. So, this is one of the last sessions. Return to sport after muscle injuries. After all these difficult talks about subscapularis and prostheses and revisions, this is maybe a little bit different. So, if you had a recent injury, one of your main concerns maybe, and your athlete will tell you that and ask you that, how soon can I return to sport? Well, the answer to this question, and all the sports medicine guys in this room will confirm that, it's not easy because each athlete is unique and each injury is unique. If you return too soon, you increase the risk of re-injury, developing a chronic problem. If you wait too long, that can lead to unnecessary deconditioning. But what can improve the recovery from an injury? And that's the major question. We today know that a high level of conditioning helps. Research has confirmed that a history of resistance training helps reducing even the risk of injury. So that means great shape can prevent injury and even lessens the severity of an injury. It also helps to reduce recovery time. So we can distinguish the acute recovery phase, and we talk about PRICE: protection, rest, ice, compression, and elevation. Activity is limited. Allow your athlete the time to heal. Before, we only used the RICE principle. Today, we add the focus to protection against future injury. After the acute recovery phase, we talk about the POLICE protocol. Protection, so maybe with assistive devices, optimal loading, ice, rest, and elevation. And eventually, but that depends on the severity of the injury, medical care, even surgery, sorts of taping, bracing, and some physical treatment forms. Don't forget the non-injured parts. Injury recovery means range of motion, strength training. Discomfort can be a guide. Avoid movements that cause pain. Muscular endurance is important. Muscle strength and flexibility up to 70% maximum capacity for a few weeks. The most common sports-related injuries mean time lost from practice, from competition. The diagnosis, we all know: history, clinical exam, ultrasound, and MRI. But currently, there is no agreement on the optimal return to play protocol, and even the utility of imaging is debated. Look at the MRI after a hamstring injury. If we should believe the protocol of the radiologist, some of our athletes would not play before 6 to 9 months. Muscle injuries comprise up to 30 to 50% of the total injuries in sports. Of these, 50% are thigh injuries, particularly hamstrings. And the problem is the high rate of recurrence. We know today that hamstrings can have a recurrence rate up to 33%. Quadriceps problems up to 20%. But unbelievable, but little progress has been made in reducing the burden of these injuries. Hamstring injuries go up more than 4% annually in professional football. And I'm a member of the UEFA Champions League study group, and we see that in every top club in Europe, the incidence of hamstring injuries go up. And we know that in a professional club, it's up to 90 days of time loss per club and per season. The problem is the cellular response to muscle injury. Changes are seen to the muscle fibers, to the surrounding extracellular matrix, and during the repair, we can see fibrosis, and that negatively affects force and range of motion, even after the patients return to play. But the function of the acutely injured muscles seem to improve with time. In Europe, some epidemiological figures, we see up to 1.5 incidents per 1,000 hours of football, much less in the US. Males seem to suffer 64% more than females, 20% recurrences in males compared to 10% of female players. So a little bit more difficult now, but I'm going to go over quickly. There is a cellular response to injury. The degeneration of the damaged muscle cells result in some tissue inflammation. Regeneration means renewal of muscle fibers and growth of the muscle tissue. Muscle renewal means proliferation, also differentiation of the satellite cells and the generation of new myofibers. The timeline is variable. The first phase is the degeneration. We see that on a cellular level. Myofibers means cell breakdown. That means release of intracellular proteins like these can act as cytokines. The serum concentration of these proteins increase, so the immune cells are activated, they are attracted to the site of the injury, and there is an inflammation of the region, followed by the macrophage-mediated response. We see phagocytosis of the debris from the necrotic muscle cells after 48 hours. So they remove the necrotic material and they suppress inflammation. The second phase, the macrophages secrete cytokines. Muscle cell precursors are activated. These cytokines include fibroblast growth factors TGF, FGF, IL-6, TGF, that helps the growth of the muscle cells and also helps the differentiation of the muscle stem cells. So the regeneration of these muscle problems begin with the proliferation of the activated myogenic cells, precursor cells. They replace the muscle fibers, and that's the repair of the damage from the injury. Non-muscle stem cells even are also meant to be capable of myogenesis, so they are able to regenerate muscle fibers, indistinguishable from the old muscle cells. What about the function of the muscle after the injury? Well, they are identical to the pre-existing muscle cells, but fibrosis can alter the physiology of the muscle cell as a whole. Fibrosis means a process of deposition of connective tissue plus abnormal extracellular matrix within the muscle tissue. Pain, stiffness, and of course a limited range of motion. So the diagnosis, I repeat, detailed history, physical examination, location, severity. We have to test the strength bilaterally. We test the range of motion after 48 hours. And what about imaging? Well, we all take an X-ray to see if there is any avulsion or calcification. Ultrasound, we talk about dynamic images today. Is the lesion old or new? And there are a couple of new and promising techniques. SWE, the shear wave elastography. STE, speckle tracking echography. Also in MRI, there are now advanced techniques. We call it DTI, diffusion tensor imaging. And that technique can detect limited molecular movement, so that can assess even muscular fibrosis. It's multifactorial. The return to sport is difficult. What is the mechanism of injury? What was the severity of the muscle injury? What muscle group was touched? As I already said, hamstrings are different from the quadriceps. Use of MRI, we tested that in our Champions League study group, As a predictor of return to play, it's still controversial. MRI, we have increases in grades, and that's correlated with the increase in numbers of day off. Of course, athletes are individuals. The type of sport is different. Return to sport may be mainly determined by clinical factors, for instance, passive SLR deficit. The function after the acute muscle injury, we still don't know. Poor prognostic factors we know and we can recognize. Hamstring strains, contact injuries, and of course, age. So there are some treatments supposed to enhance return to sport. Steroid injections has been used for so many years. My grandfather already used it 50 years ago. But it's still controversial, particularly for tendons and ligaments. Intramuscular or myotendinous junction injections maybe not carry the same risk. Today, a lot has been said, and also in this meeting, interesting lectures about PRP, about tissue healing factors. But most studies say there might be a fast return to sport, but there is no difference after 28 days. Excuse me. We talk about antifibrotics as the gamma interferon, decorin, relaxin. RCTs are necessary. The same for losartan, what's an angiotensin 2 receptor blocker. The potential to decrease fibrosis can improve muscle healing, and again, RCTs are needed. Muscle-derived cells, the MDSC, could promote angiogenesis and decrease the fibrosis. What about the biomaterials as a delivery vehicle? We don't know. So, conclusion, clinical exam, ultrasound, MRI. Muscle function is not 100% upon return to play, though it can improve with time. Caveat, clinical factors associated with prolonged return to play. Delayed presentation, presence of a structural injury and a stretch type injury mechanism. So the take-home message, the guidelines are no pain in movements, pain-free full range of motion, symptom-free, no swelling, return of strength, demonstrate greater than or equal to 90% of the contralateral muscle maximum voluntary isometric contraction strength, 90%. Good flexibility is necessary. Sufficient proprioception, restoration of sport-specific skills, functional retraining, restore, don't forget that, restore and promote the cardiovascular function. And I put it in bigger letters, the mental confidence in the ability to do exercises. And we as doctors, we should provide for continued equipment modification as bracing, orthosis. But also continue communication with the player, the family, the rehab network, the coaches. Ready to return should be tested with the correct functional evaluation tests. Thank you.